All right, this is the Nursing Care of Burns Patient lecture. This voiceover is being recorded at a later time as the audio from the live session was not working. So in today's lesson, learning objectives include discussing the pathophysiology of burns, identifying prevention measures, listing risk factors, describing the system effects of major burns, describing nursing care, medications and procedures, and describing patient education related to burns. So who's at risk for burns in general? Well, anyone who's exposed to sources of burns, anyone who's exposed to sources of heat or flame or explosives or hot liquids, chemicals or radiation. So if you're cooking dinner, you are putting yourself at risk to burns. If you're playing with fireworks for a holiday, you're putting yourself at risk to burns. And also, in addition, the very young and the very old are at higher risk. The very young, because they lack compensatory mechanisms when they do get burned really bad. And the amount of body surface area that can be impacted is much higher. So imagine that you accidentally spill some boiling water on your leg. And it's covering a small portion of your leg, but imagine that same amount of skin damage on a newborn or an infant. It would cover a much larger portion of their body, and the percent of the body surface area that's burned has an impact on the extent of the illness. And then the very old, also because they just lack the compensatory mechanisms to handle the burn shock that can happen, as well as they have more skin frailty. Their skin is more at risk for damage. So obviously prevention is better than treatment. And so we want to teach our patients to prevent burns from happening. So some community education that can happen is things like encouraging patients to have functional smoke detectors and fire extinguishers, making household plans for fires, teaching stop, drop, and roll if you do light on fire, teaching patients and families to store matches and lighters out of the reach of children, turning pot handles inward or using the back burners so that little hands can't reach up and grab hot things off the stove, covering electrical outlets so little hands don't stick things like knives and metal objects into electrical sockets, keeping water heaters less than 120 degrees to prevent scald burns, wearing gloves when handling chemicals, avoiding tanning beds, avoiding smoking in bed, don't light flammable substances to an open flame. So in other words, don't be pouring lighter fluid onto a charcoal grill, and avoid the use of fireworks. So if we can prevent burns from happening, it's going to be a lot easier than treating it. Now, in order to understand burns, first we have to understand the physiology of the skin, what is composed in the skin, and what is in each layer is going to make an impact on the type of injury and signs and symptoms that you're going to notice. So as we go through this, pay attention not only to the different levels, but what each level contains and what it's good for. So the very top layer of the skin is the epidermis. It's a very thin layer, and it provides that primary prevention from exposure to the environment. So it is that physical barrier between us and the environment, preventing infection. And then the dermis is the thicker layer in the middle, and it contains a lot of things that we need in skin to regenerate skin. It contains blood vessels and nerve endings and oil glands, and importantly, cells that regenerate new skin cells. And then the hypodermis, or the subcutaneous fat, is this bottom layer where the adipose tissue is. It's a fatty layer. There's also blood vessels and nerve endings there. And that fatty layer insulates the body and provides temperature control or thermoregulation. And then we have to think not only these layers of the skin, but what's beneath the skin. So beneath the skin is bone and muscle, and those things help us with functional movement and range of motion. And in severe burns, even the bone and muscle can be involved. So what is a burn? Burn at the core, or at the basic definition, is damage to one or more layers of skin. Now, there are different types of burns. Thermal burns happen from things like fire and steam and heat. And when we're thinking of thermal burns, we might think about things like sunburns or burning yourself on a hot pot, but we also have to think about airway and breathing because of inhalation injury. So if a patient's in a house fire, they're more likely to die from an inhalation injury than they are from the actual skin burn. So if they inhale really hot vapors or hot air into their nasal cavities and throat, it can actually cause inhalation injuries and cause the throat to swell. So we've got to make sure that we consider their airway. And if we're at all concerned about an inhalation injury, making sure that we get them intubated before their throat starts swelling shut. The second cause of burns is electrical burns. Now, electrical burns can happen from things like getting electrocuted when changing a light if you didn't turn off the fuse box, or it can be things like getting struck by lightning. And the damage here is really unseen. It's kind of like the tip of an iceberg. So you're going to notice an entry wound and an exit wound, but it's all of the damage that happens internally as the electricity current moves through the body that can cause harm. And specifically, it can cause things like cardiac dysrhythmias, and it can cause kidney damage. And it causes kidney damage because when the muscles that are damaged in an electrical burn start releasing myoglobin into the bloodstream. So when muscles damaged, it releases myoglobin into the bloodstream. And unfortunately, myoglobin is a large molecule that gets stuck in the tubules of the kidneys. The kidneys cannot filter myoglobin effectively. And so they get all bogged down and stuffed up with myoglobin, which can cause acute kidney injury. So when we're thinking of electrical burns, we're going to be having a high suspicion for cardiac dysrhythmias due to the electrical activity, and kidney damage and muscle damage. Now, 3 other kinds of causes of burns can be chemical burns, and this can be from gases or powders or liquids. Cold burns from things like frostbite, exposure to the elements. And even our oncology patients are exposed to radiation burns when they go for radiation treatment, and they'll get radiation burns on their skin. So once we know these different layers of the skin, it kind of helps us understand how burns are staged. So burns are staged by 1st, 2nd, 3rd, and 4th degree, and it depends on how much of the skin is affected. So 1st degree, we'll get into each of these now. So first, we can call them either 1st, 2nd, 3rd, and 4th, or we can call them superficial, partial thickness, full thickness, and deep full thickness. So for 1st degree or superficial burns, it's only that top layer of the skin that's impacted, the epidermis. These burns will appear very red or pink. They will be very painful to the touch, and they'll be warm. No blisters will be present. If you palpate the burn, it will have a brisk cap refill, and it will be blanchable. These wounds are typically self-healing and don't require any medical care. The best example of this is like a sunburn. 2nd degree burns or partial thickness burns can be subcategorized into superficial partial or deep partial. Now, in partial thickness burns, both the epidermis and the dermis are affected, and how much and how deep into the dermis the burn goes will determine if it's a superficial partial or a deep partial. Severity will vary on whether it's how far into the dermis this burn extends, and these are very painful. And as you see in this picture, blistering is very common in 2nd degree burns. The burn will appear shiny and moist. There is a risk for scarring with these kind of burns. The skin will be blanchable, so if you did press it, it would blanch. And because the cells that regenerate new skin cells are found in the deep part of the dermis, deep partial superficial or 2nd degree deep partial burns will require a skin graft because the cells that could regenerate skin have been burned away. Now, full thickness or third degree burns affect all the way down into the hypodermis. So the epidermis and the dermis are completely destroyed, and the hypodermis or the subcutaneous tissue is affected. And these patients will have either no pain or very little pain because the nerve endings that allow for pain sensation have been burned away in the dermal layer. And because those skin cells that regenerate new skin have been burned away, the skin cannot self-heal, and this patient will require skin grafts. So skin graft is required, and more interestingly, with full thickness burns is because the subcutaneous or hypodermis layer is affected, the patient is going to have issues with thermoregulation, because remember, it's that subcutaneous fat that provides insulation to the body. And so with patients with full thickness burns, the burn unit room has to be kept to a room temperature of 85 to 100 degrees Fahrenheit in order to provide thermoregulation to the patient. Now, these burns will appear black, yellow, red, matte, or dry, and there will be eschar noted in some areas. So what is eschar? Eschar is burned dead tissue. It's this black charred skin, and it looks hard and leathery. And the damage or the risk with eschar is that it limits circulation and even breathing because it is so hard and it doesn't allow it to expand. So eschar has to be surgically debrided or have some kind of wound debridement, meaning it has to be removed. Otherwise, skin cannot regenerate and heal. Now, a red flag with eschar is either whether the eschar is circumferential, meaning wrapping all the way around a limb, or if there's a lot of eschar noted to the chest. And that's because, again, having this be hard and leathery and limiting movement, if it's circumferential, it has a risk for compartment syndrome, cutting off blood flow to that limb. And if it's on the chest, it can cause breathing problems for the patient as they have a hard time getting good expansion of their lungs. Now, fourth degree or deep full thickness requires that all of the layers of the skin, the epidermis, the dermis, and the subcutaneous tissue are all destroyed. And in these burns, it extends way down below the layers of the skin to the muscles and the ligaments and bone. The skin will look charred and black from the eschar, and of course, skin grafting will be required. Now, in order to categorize burn severity, there are a couple of considerations we have to think about. First of all is the burn stage, which we just discussed. The next is what % of the total body surface area has been impacted, because the greater the amount of total body surface area impacted, the more likely the patient is to have problems with perfusion and have shock because of the increased capillary permeability. So fluid and electrolyte shifts become a risk with increased total body surface area burned. Of course, the very young or the very old will increase severity. Medical history of comorbidities, things like heart failure or diabetes, will make wound healing more complicated. And then the location of the burn, whether the burn is on the face, affecting the face, the eyes, the nose, the ears, the mouth, the throat, the hands, the feet, and then the perineum and the buttocks. And those areas specifically are troublesome because they either impact function, like seeing and hearing and breathing, the ability to use your hands and feet to be mobile and move around. And with the perineum and buttocks, it is really hard to keep those wounds clean. And so those patients run a higher risk of infection. So what do we qualify as a minor burn? Well, the definition of minor burn is either full thickness of less than 2% total body surface area, or a partial thickness burn of less than 10% of a total body surface area. These patients can either be treated at home or seen in the emergency room or urgent care and then sent home to manage these burns. A moderate burn is defined as full thickness of 2 to 10% total body surface area, or a partial thickness of 15 to 25% total body surface area. These patients typically have to be seen at the hospital. They'll be treated at the scene by the paramedics and then transferred to the hospital. And these patients are likely able to be treated at a regular comprehensive medical center, or depending on resources, they may be transferred to a burn center. A major burn is the most severe type and is defined as full thickness of greater than 10% of the total body surface area, or partial thickness greater than 25% of the total body surface area, and or a couple of other criteria that make these burns more complicated, such as advanced age, comorbidities, including cardiac, pulmonary, or endocrine issues. If it's an electrical burn, because we're worried about the kidneys and we're worried about cardiac dysrhythmias. If there was any risk for inhalation injury, because we're worried about swelling of the airway. And if there's any burns to those locations that make healing or function more tricky, the eyes, the ears, the face, the hand, the feet, and the perineum and the buttocks. Now, major burn victims, of course, have to be treated at a burn center. But before they go to the burn center, the paramedics are going to take that patient to the closest ER possible because they need emergency stabilization. They need to be intubated before their airway swells. They need massive amounts of fluid started. They need IVs put in before their skin starts swelling and it's impossible to get a line. So these patients will be transported to the nearest ER for stabilization and then transferred from there via critical care ambulance to the closest burn center. So we talked about how you need to know the total body surface area in order to determine burn severity. And so here's how we do that. There's actually two ways to calculate total body surface area burned. The first is the Palmer method. Using the palm of the hand, not including your fingers, is about 1% of total body surface area. And of course, that's the patient size of their hand. And so this works better if there's a small amount of burn or it's a scattered burn pattern. So you can kind of estimate how many palms of surface area are affected. And each palm of the hand, not including the fingers, is 1% total body surface area. And then the second way that we you calculate total body surface area is the rule of nines. So the rule of nines gives different percentages to different parts of the body. And you'll notice in this very sophisticated diagram that both the front and the back have separate calculations for percentages. So you'll notice here on our Frosty the Snowman diagram that the front of the head is worth 4.5% and the back of the head is worth another 4.5%. So if the entire head, front and back, was completely burned, that would be a total of 9% total body surface area. 4.5 for the front, 4.5 for the back. You'll notice again, on the front of the chest is 9%. The front of the abdomen is 9%. So if the front and the back of the chest were burned, that would be 9 plus 9, or 18%. The abdomen front is 9, the abdomen back is 9, the perineum is 1%. Each leg is 9% on the front, 9% on the back, and so forth. So again, if it's the entire arm is burned, it's 4.5 plus 4.5 for front and back. So let's give an example here. A 45-year-old male patient has sustained burns to the back of the left arm, posterior chest and abdomen, front and back of the left leg, anterior head and neck, and the perineum. So let's go ahead and calculate this. So the back of the left arm is 4.5%. The posterior chest and abdomen is 9% for the posterior chest and 9% for the posterior abdomen. The front and back of the left leg is 9% for the front of the left leg, 9% for the back, or 18. Anterior head and neck is 4.5, and then the perineum is 1%. So this makes it patient has a 46% total body surface area burned, which would qualify obviously as a major burn to the body. Almost half of their body is burned. So when a patient does have a major burn, it not only affects the skin, but it really impacts almost every system of the body in major ways and requires significant life-saving intervention in order for this patient to recover. So we're going to talk a little bit about the system effects of major burns. Starting with the respiratory system. The first risk of the respiratory system is carbon monoxide poisoning. So when patients are in like house fires, for example, they can start inhaling carbon monoxide into their lungs. And the tricky thing with carbon monoxide is that gas replaces oxygen in the hemoglobin. So we know that our hemoglobin typically transports oxygen through our bloodstream down to our organs to give our organs the oxygen they need to survive. But carbon monoxide kicks the oxygen off of hemoglobin and forces the hemoglobin to transport carbon monoxide throughout the body instead of oxygen. So basically the body is suffocating from the inside. Now, the tricky part with carbon monoxide poisoning is that when you put the pulse oximeter on a patient's finger to check their pulse ox, what that measures is what percentage of hemoglobin is saturated with a gas. And the pulse ox doesn't know the difference between oxygen and carbon monoxide. And so when the pulse ox is reading the hemoglobin in that patient's capillaries, it's noting that 100% of those hemoglobin are carrying gas. And so a patient with carbon monoxide poisoning will present with 100% on the pulse oximeter reading. But that's because their hemoglobin is 100% saturated with carbon monoxide, not oxygen. So if you suspect carbon monoxide poisoning based on the description of the situation that happened, or if the patient presents with any of these symptoms listed here, you're going to want to request a carboxyhemoglobin blood test. It's the only way to determine if carbon monoxide poisoning is present. And we determine that if a patient has a carboxyhemoglobin level greater than 15%, that they do in fact have carbon monoxide poisoning. Now, signs and symptoms of this would include a bright cherry red color to the lips or the skin. The patient may be drowsy or have altered mental status or dizziness. They may have a headache or have nausea and vomiting or even a loss of consciousness. Treatment for this is 100% O2 on a non-rebreather mask that will help replace the carbon monoxide in those hemoglobin back with oxygen and give the body the oxygen it needs. The second complication with the respiratory system with major burns is an inhalation injury. Inhalation injury is the main cause of death in house fires, and we need to have a high level of suspicion if we suspect an inhalation injury, because these patients' airways will swell extremely quickly and extremely severely. And so you notice down here in this third picture how swollen this patient's face is. And you can see that they're intubated, but could you imagine the doctor trying to intubate the patient after all this swelling happens? It would be virtually impossible. It could be impossible. And so we actually intubate before the swelling happens if we suspect an inhalation injury has happened. So how would you suspect that? Well, you would hear risk factors like the patient was in a house fire. You would notice things like if there were burns to the face, if their nose hairs were singed, if they're coughing up carbaceous sputum, black sputum, or if they have sooty nose or mouth, if they have that cherry red skin or lips, a site of carbon monoxide poisoning, if their voice sounds hoarse, or if they were involved in a burn in an enclosed area. They also may present with an increased respiratory or heart rate, altered mental status, or confusion and anxiety. So the treatment for this is to intubate immediately before swelling happens, check their carboxyhemoglobin level, and then the pulmonologist would do a bronchoscopy to get a camera down into their airway to assess the damage and see if there was any burn injuries, inhalation injuries to the airway itself. Now, for the cardiovascular system, one of the risk factors here is compartment syndrome, and that's related to the tightness that can happen from eschar and from all the third spacing of fluid. So this is more common with full thickness burns, and it can happen from the eschar and with circumferential burns. So with circumferential burns, again, the eschar cuts off circulation to that extremity, and makes blood flow almost impossible. And so we want to make sure that those extremities are still getting the oxygen they need, the blood flow they need. So we'll be checking pulses and respirations and cap refill. We can prevent compartment syndrome by elevating burned limbs above the heart to promote venous return to the heart. And the patient may require an emergent eschorotomy or fasciotomy to help relieve that pressure and allow perfusion to occur in that limb. So eschorotomy is just a slit through the eschar to relieve some of that pressure. And a fasciotomy is just a slit through the skin to relieve some of that pressure. And you're seeing a fasciotomy in that second picture there. So be aware of the risk for compartment syndrome with patients with major burns, especially circumferential burns. Now, the other thing that happens with the cardiovascular system, and probably the most concerning that threatens life in the first 24 to 48 hours after a burn, is burn shock. Burn shock happens when the total body surface area of burns is greater than 15%. And the capillaries, all those tiny little blood vessels in the body, spring leaks. They start getting leaky everywhere. And so all of the blood that should be flowing through the bloodstream is now just leaking out into the tissue all over the body. And so the patient is going to look so swollen, and their blood pressure is going to drop to nothing because their blood is no longer in the blood vessels where it belongs. It's just leaking out into the tissue. This capillary permeability happens within the first 1 to 2 days after the burn. Not only that, but the patients can have fluid loss through evaporation from these large burns. In fact, they can lose up to 5 liters a day just from evaporation from the fluids from the wounds every day until those wounds are closed. So of course, we're going to monitor for hypotension, and we may notice increased hematocrit as the blood that is left in the bloodstream becomes much more concentrated. Potassium can increase, as potassium is an intracellular electrolyte. And so when cells are damaged, they can open up and spill their contents out into the bloodstream. So we can see hyperkalemia because the cells are damaged, spilling potassium into the bloodstream. Additionally, we can see sodium drop because sodium follows water. And if all the water and all the fluids from the blood are leaking out into the tissue, sodium's leaking out into the tissue as well. So in general, we're going to be really watching for these electrolyte imbalances and fluid volume deficit in those first 24 to 48 hours of a major burn. Now, treatment for burn shock is aggressive fluid replacement. So you need 2 large bore IVs or even a central line, and you want to get those before the patient starts having all this massive swelling. The patient is going to be on isotonic fluids. We're just looking for fluid volume replacement. We're not trying to shift fluid in or out of the cells. And then the other thing we may add is albumin. Albumin is the protein created by the liver that works like a water magnet. And so if we can infuse albumin into the bloodstream, the idea is that it will suck all that third spacing liquid, water and blood back into the vascular space, which would increase their blood pressure. Now, I think shock is a topic you haven't covered yet. And so just kind of as an overview, shock just means a lack of oxygen to the tissues or organs because of lack of perfusion. And so if all the fluid is leaking out into the tissue and not in the bloodstream, then the organs of the body aren't getting the blood flow and perfusion and oxygen that they need. So we know that aggressive fluid replacement in those first 24 to 48 hours is important, but how much fluid specifically do we give? Well, in order to determine that, we follow the Parkland burn formula. So the Parkland burn formula is 4 mLs times the percent of total body surface area burned times the patient's weight in kilos. Once you have that number, you're going to divide it in 2. And you're going to give half of that in the first 8 hours and the other half of that total number in the next 16 hours. So let's see what this looks like. This is our patient from earlier with the 46% total body surface area, the major burn. This patient weighs 80 kilos. And so the Parkland burn formula says 4 times the percent of body surface area times the patient's weight in kilos. So 4 times 46 times 80 kilos equals 14,720 mLs. Think about that. That's almost 15 liters of IV fluids, 15 bags of saline in the first 24 hours alone. And we're going to give half of that in the first 8 hours. So what's half of that? Well, it's 7,360. Well, we need to figure out how do we give that over 8 hours. And so we're going to divide that by 8 so that we can decide what to set our pump at. So we're going to divide that number by 8, which is 920 mLs per hour for the first 8 hours. Now for the other 16 hours, we're going to give the other half, the other 7,360 mLs, and we're going to divide that over 16 hours. So we'll be setting our pump at 460 mLs per hour for the next 16 hours. And this is just to try to keep up with the amount of third spacing of capillary leakiness that happens in those first 24 hours following the injury. So the renal system can also be impacted by a major burn. The patient is likely to be oliguric, meaning low urine output in the first 24 to 48 hours. And that's just, again, because there's not a lot of blood flow going on through the vascular space. So this patient is at risk for acute kidney injury and even acute kidney failure. And this is going to be due to things like myoglobin collecting in the tubules. The myoglobin, remember, is those large molecules that muscles release when they're damaged. So myoglobin is spilling out of the muscles into the bloodstream and then clogging up the kidneys. After the first 1 or 2 days, then the patient is going to start diuresing. The capillary permeability returns to normal. And so all of those liters of fluid that we just put in, those 14-liter bags in the first 24 hours, the patient is finally going to start diuresing those. Now, you'll know the patient is having myoglobin in problems if you notice that their Foley bag looks like Coca-Cola is in there. That dark Coca-Cola colored urine is what we notice when myoglobin is present. And so how do we treat this risk for acute kidney injury and help flush this myoglobin through the kidneys? Well, we're going to do strict I&O. And we're going to continue to push those fluids per the Parkland burn formula with the goal of having a urine output of minimum of 30 mLs per hour. And of course, this patient is going to need a Foley. Now, even the gastrointestinal and metabolic systems can be impacted. And this is because the GI system gets decreased perfusion, decreased blood flow, and also because of the opioids that we use to treat patients with pain. Because remember, even if patients have major burns, where all the nerve endings are killed off, and so they shouldn't have pain, even around the edges of those major burns, there's likely to be first and second degree burns, which can be very painful. So burn patients do need a lot of pain medication. But as far as the GI system goes, what we learned last year was that acid increases in the stomach when the patient is under stress. And this can be emotional, mental stress, but it can also be physiologic stress. And so the physical stress that the patient's body is enduring causes increased acid production in the stomach, which can cause a risk for stomach ulcers. And so those patients are put on antacids prophylactically to prevent the risk of stomach ulcers. Additionally, we're going to notice decreased motility of the gut, decreased peristalsis. The patient may have constipation, or at worst case scenario, paralytic ileus, where the gut stops moving altogether. And we are going to want to check these things by checking bowel sounds and checking for any nausea or vomiting. We're going to probably need to put in an NG tube to help with gastric decompression. The patient will be NPO in the emergent phase, the first phase of healing, for the first couple days, because their gut just can't handle any food. And then the last thing we're going to notice is decreased function. And by that, I mean poor nutritional absorption. So even if they are fed, their body is so busy trying to heal that it's not going to absorb the nutrients very well. So these patients may need to be on total parenteral nutrition. That's basically like a formula that's put directly into the IV and bypasses the gut altogether. And their nutritional needs are going to be high calorie, high protein, high carbohydrates. And we're going to monitor for hyperglycemia in these patients, because remember, one of the 4 S's that can cause hyperglycemia is stress. And these patients are under significant physiologic stress. And so they may have hyperglycemia even if they're not diabetic. Now, of course, the immune system is at risk for being a problem as well, because the physical barrier of the skin, which is our primary barrier for preventing infection, has been removed. And so these patients are at higher risk for infection. Plus, they often have a low white blood cell count because their white blood cells have been all kind of used up trying to recover from this injury. And who is at risk for infection? Patients with burns to the perineum and the buttocks are at higher risk due to the difficulty of keeping those wounds clean. And then patients, of course, with major burns, because there's increased surface area of their body is exposed to the elements, more likely to get infected. So patients with major burns in the burn unit have to be on protective isolation. And that means anyone going into that room has to wear hair covers and gloves and gowns and masks and shoe covers. And remember, in a major burn room, we're cranking the thermostat up to 85 to 100 degrees because the patient isn't able to thermoregulate because they've lost their subcutaneous fat. And so could you imagine being all gowned and gloved up and working with these patients for hours at an end in a 90-degree room? The patients are going to need to have sterile linens on their bed because this is not the kind of patient that you can just pull some linen out of a linen warmer. They really need sterile linens to prevent infection. And nurses will be wearing sterile gloves when doing wound care and patient care for these patients. Now, the dermatologic system is impacted. Remember about that temperature dysregulation. And when a patient is cold, what do we do when we're cold? We shiver, right? Well, shivering actually increases the oxygen demand of the body, the metabolic demand of the body. And so shivering is only going to make everything worse. So we don't want our patients to shiver. So we're going to keep that room at 85 to 100 degrees to encourage thermoregulation. And then we're going to need to treat pain. So remember, these patients can be in severe pain. The 3rd and 4th degree burns, of course, they're not going to have pain because the nerve endings have been burned off, but around the edges of those wounds, there can be 1st and 2nd degree burns that can cause significant pain. So these patients are going to need IV pain medication, and these patients need to be pre-medicated for wound care. So that they've got medication on board before any wound care is done. Now, wound care is going to be a significant part of this patient's recovery. They may need hydrotherapy baths or wound debridement scrubs, or they may go to the surgical unit for debridement or have chemicals put on their skin to debride the wounds. But all that old dead skin has to be debrided, meaning removed, in order for skin grafts to be applied or wound healing to happen. And so before all those activities happen, pre-medication for pain is going to be important. And when we do wound care, of course, the dressings will be sterile dressings. We're going to be assessing for any odors or drainage or discharge, assessing for sloughing, eschar, bleeding, and skin regeneration. We're going to cleanse thoroughly, removing all previous ointments before applying new one. We're going to dress wound areas separately to prevent webbing and kind of sticking of the gauze between wounds. And then debridement will be a common treatment, meaning removal of the dead skin. This can be mechanical through things like surgical removal in the OR. It can be done through hydrotherapy showers or whirlpools, or chemical debridement. We'll need to help with range of motion exercises to maintain mobility of the joints and tendons and ligaments, and of course, pre-medicate them for pain. Wound care medications. There are 4 topical medications listed here that all help promote healing and reduce infection. These are all listed on page 504 of your ATI book, in your medical surgical ATI review book. And I would encourage you to look through these on your own to review these 4 medications. And just as an aside, chapter 75 of your Med-Surg ATI book is all about burn care and provides a really good synopsis of everything we're covering today. And I'd encourage you to use that as a resource as you study this material. So some wound care procedures and treatments that can be done. We've already talked about eschorotomies and fasciotomies. We've talked about wound debridement, but what we haven't talked about yet is skin covering, skin grafts, and cosmetic reconstructive surgery. So skin coverings need to be applied when the body is not going to be able to restore its own tissue. And these have to be applied so that we can reduce the risk of infection and improve thermoregulation. Now, skin coverings can be either biologic or synthetic. An allograft comes from human cadaver skin. A xenograft or heterograft is from pig skin. Amnion is from a human placenta, and synthetic comes from silicone or plastic. So skin grafts are done. Skin grafts can, again, be any of these types of skin coverings to close wounds and prevent infection. And then once the patient is healed, they may require some cosmetic reconstructive surgery to restore appearances as well. So when patients have skin grafts, a few things to remember. We want to elevate those extremities to promote venous return to the heart. Provide wound care to the donor site. So sometimes patients will have balloons put under their skin to help stretch their own skin so that their skin can be used to cover their own wounds. So don't forget about, when you're taking care of the burn area, that you're also taking care of the donor site where skin was removed. We're going to monitor for infections, monitor for body temperature, and perform range of motion activities to prevent contractures. So the final thing we're going to talk about here are the different phases of burn management. And these phases of burn management can be divided into 3 sections: the emergent phase, the acute phase, and the rehabilitative phase. In the emergent phase, that happens in the first 24 to 48 hours after injury. And this is qualified as from the onset of injury to the restoration of capillary permeability. Remember, the capillaries are going to be crazy leaky in the first 1 to 2 days. And all of that fluid is going to be just third spacing. And these patients are going to get so swollen from their head to their toe. And that is the emergent phase. And then the acute phase is after that. Really from 48 hours after injury until the wounds are healed. And then finally, the rehabilitative phase, from when burns are healed until full function is restored, both mental and physical. So in that emergent phase, again, the first 24 to 48 hours after an injury, when capillary permeability happens, this is when the patient is at risk for shock. Remember, lack of perfusion to the organs due to poor blood flow. And so the major focuses in this emergent phase is going to be on fluids and electrolytes, following that Parkland-Burn formula to pump massive amounts of isotonic fluids into these patients, monitoring for electrolyte shifts, monitoring their airway and intubating early if there's any risk at all of an inhalation injury, and monitoring for some of those other complications like compartment syndrome and acute renal failure due to the kidney issues and the muscles dumping myoglobin into the bloodstream. In the acute phase, about 48 hours after the injury, until the wound healing happens, this is when those capillaries start behaving again. They're no longer leaky. And so all of that third spaced fluid is returning to the bloodstream. And so the kidneys have to kick into high gear and diurese all of that liquid. Remember that our patient that we've had in this lecture today, we were giving him like 15 liters of fluid in the first 24 hours. So all of that fluid has to come out. And so the kidneys are going to be diuresing like crazy. And of course, there's a risk during this phase of infection because these wounds are still open. So the foci for this section is to prevent infection, monitor pain management, provide optimal nutrition, and wound care and closure. Remember when we talked about nutrition as a topic and tissue integrity, we talked about how when patients have poor tissue integrity and they have wounds, they need extra protein and vitamin C in order to promote good wound healing. Well, think about that on a major scale. If half this patient's body is covered with burns, then their nutritional demands for things like protein and calories just go even more. So nutrition is going to be a major focus for this time. And then in the rehabilitative phase, this is once the wounds have healed, and the patient needs time to return to normal function. They may have been hospitalized for weeks to months, and their focus here is on physical and mental recovery, PT and OT, activities of daily living, cosmetic corrections, mental health care to deal with the disabilities that they may be facing now, and then treatments and therapy to help with long-term disabilities, especially if things like their eyes, their hands, or their feet were affected by these burns. Of course, a patient with a major burn is going to have a major team caring for them. And it's in our scope of practice as nurses to coordinate care. And so think about all of the different people that need to be involved in this patient's care. Doctors and nurses and advanced practice nurses, wound care techs, hospital intensive doctors, clergy, environmental service, PT, OT, nutrition, social work, the list goes on. And it's our job to make sure that these patients have all of the resources that they need. And finally, during the rehabilitative phase, the kinds of things we're going to be teaching our patient is how to prevent infection, providing social and emotional support, offering resources for support groups, what to expect about scar appearances. If they're told to wear compression garments, we have to instruct them to wear them 23 hours a day to minimize scarring and prevent difficulties with mobility. Patients should be taught to massage their scars with moisturizers daily, to avoid tight clothing, which can irritate the healing wounds, and that these patients are probably going to need follow-up appointments for 2 years after their burn. So this is a patient that will be seen in the clinic regularly. And that's what you need to know about burn care. Thanks so much for listening. Have a great day.